Okay, so finally we've got Leslie Chang from Minnesota, who's going to present some data from their clinical trial of adjuvant radiation for Dupuytren's disease.
Hi, thank you so much for the opportunity to present. This is our study looking at the safety and efficacy of early adjuvant radiation in combination with contracture release in the treatment of Dupuytren's disease. I'm currently an assistant professor of radiation oncology at the University of Minnesota. We have no conflicts of interest. So as you know, stage prior to radiation is the most important prognostic factor for the efficacy of radiation in patients who have early N0 or N1 Tubiana stage. We know that radiation is very effective in decreasing the percentage of patients who progress. However, in patients who have later stage degree of contracture, radiation is not as effective, and these patients often have many comorbidities from their level of contracture and may need surgical release. This led to our study, which is a prospective single-arm study to determine patient-reported hand function using the Southampton Dupuytren scoring system after contracture release and using early post-operative radiation. Our secondary outcomes are recurrence rate of nodules and contracture and adverse events. So our study schema looked at patients who are greater than 18 years old, who do have a documented contracture from Dupuytren's disease and are candidates for surgical intervention, and that includes Clostridium injection, needle aponeurotomy, or open fasciectomy. And prior surgical procedures are allowed because many of these patients have had prior treatments, but with regression of disease. Our treatment was delivered using early adjuvant radiation treatment, ideally within 4 weeks of their surgical intervention, using electron beam radiation, again, 2 courses, 15 gray, 6 to 8 weeks apart. And we evaluated at 6 weeks post-radiation, 1 year and 2 years. And our outcomes, again, are the Southampton Dupuytren score, clinical symptoms, and adverse events. So this is our study demographics. Again, this is an interim analysis, and the study is still open for enrollment. But currently, we have enrolled a total of 12 patients with 15 different hands. You can see that the prevalence is older with a median age of 60 and prevalently white male patients, many of which have family history of Dupuytren's disease and potentially a history of other fibromatosis, including Lederhose and Peyronie's disease. The time to radiation for the majority of these patients is relatively quick, 12 days post their surgical release. And 80% of these patients had a prior surgery. So this is a very heavily pre-treated population. Many of these patients had open fasciectomy. We had a small minority that did receive needle aponeurotomy, and 90% of patients completed radiation as planned. In terms of our results, the Southampton's Dupuytren score significantly decreased per hand for patient from a mean of 5.4 preoperatively and prior to radiation to 3.3 at last follow-up. And this is very significant because this is a patient-reported outcome in terms of hand function, so their ability to grasp, their ability to do hobbies, and their ability to use their hand for their functional interests. We also found that in this highly pretreated population, there was overall an increase in degree of contracture over time. One hand had developed a new nodule in the treatment field, but you can see that per hand, the results are very varied. And anecdotally, it looks like pinkies, as we've seen yesterday, were at higher risk of recurrence, and hands that had a higher degree of contracture prior to surgery were also at higher risk of recurrence. So in the minority of patients, approximately 30%, there was a significant increase in degree of contracture because of those characteristics, and they were all in hands that were previously treated with a surgery or other intervention. In terms of adverse events after surgery and radiation, again, we found that the majority of side effects were minimal. Grade 1 dry skin was the most common adverse event found in 4 hands. We had also found some skin fibrosis or tightness symptomatically in patients. There was one grade 4 adverse event, and that was post-operative ischemia. This occurred in a hand that had 3 prior surgeries, and the patient did not complete radiation secondary to that event. Numbness after open fasciectomy is also a risk, and so 2 hands did have that event as well. So in conclusion, we know that adjuvant radiation after contracture release surgery using split course 30 gray and 10 fractions is well tolerated, particularly in this population who've had repeated or recurrent contracture after prior surgical intervention. The Southampton's Dupuytren score had significantly improved after treatment with both surgery and radiation, with a mean change of negative 1.9 points. And the most common adverse events were minimal after surgery and radiation, and most commonly were grade 1 skin dryness. Longer follow-up is needed in this population to understand the duration of symptomatic improvement and recurrence rate of contractures and nodules, but we do believe that this data demonstrates that this is an effective treatment regimen, especially for patients who you might be more hesitant to treat in a prior pre-treated population. I want to acknowledge our team at the University of Minnesota. Dr. Dusenberry is here in the audience today and has really spearheaded this in our institution, but this can't be done without our residents, medical students, research coordinators, and our orthopedic surgery colleagues. So thank you so much, and I welcome any questions.
We've got a couple of minutes. I'd actually like to hear from a surgeon about what they think about this.
Sorry, I'm not a surgeon yet. I have a question about I think you included 12 patients with 15 hands, so probably a couple of those hands are attached to the same patient. And I was wondering if you look at confounding at all, because 2 hands in one patient have the same genetics, the same patient characteristics. So can you comment on if you actually adjust for the confounding?
So we did not adjust for confounding of using the same patient just because of the minimal number of hands that are on study. But we did find that in terms of the degree of contracture, it really depended on the amount of pre-treatment. So in the same patient, for example, in patients who had recurrence of contracture after radiation and surgery, those were in patients who had greater than 100 degree of contracture initially. And so in their other hand, where they had 0 to 10%, so to be on a stage N1, they actually did not have significant increase of recontracture. So in that population, I think it does suggest that the morphology of the patient's contracture prior to treatment and the amount of pre-treatment they had were greater factors for long-term contracture recurrence than individual genetics depending on the treatment.
Great. Well, look, I'm sorry, we've got other questions in the audience, but the red flashing light's going on in the background, and I think the next session has to kick off. So thank you, Leslie.